Welcome to Consulting Chike and welcome to yet another video on hospital operations. This is the part 2 of 3 parts and this is under the hospital basics. So let's get started. So in this video we'll be covering about CSSD operations, BMW management, then housekeeping and infection control routines, then laboratory operations, radiology imaging operations, OT management, then manpower rostering and shift management. CSSD operations. So CSSD operations starts when you have your instruments coming from the OT from different parts of the hospital to the CSSD. So the used instruments comes to the CSSD, they are received. Okay. Then after that, so once you receive the instrument, you make a count and you register it where from where those instruments has come and what sets are there. Then you do a cleaning and washing. If you have a good CSSD setup, you may have ETO, you may have autoclave. Autoclave though it's mandatory. So after cleaning and washing, once it is done properly, it is packaged. So those instruments are packed with clothes in a tray, or there are certain packaging materials available commercially, so those are used. Then the sterilization part. So in the packages, your indicators are in each batch of the autoclave, indicators are put, and then sterilization process is carried out. So in general, for sterilization there are 3 criteria that has to meet. One is the temperature, second is the pressure, and third is the time, holding time. So in general, temperature 121 degrees Celsius, 15 psi, and you have to hold these 2 conditions for 30 minutes. So this is for general biomedical waste, for general instrument. And then for biomedical waste, you have to do it for 60 minutes. Okay, so once the sterilization is over, then you have to label with the batch number. So batch number has to be unique. Then after labeling, you have to store it. Then it is dispatched to different areas. Okay. So and the second aspect of this is CSSD operations is the quality checks. So in quality checks, what you do daily basis, you do a Biomedical test. So Biomedical test ensures that the pressure is uniformly present inside the autoclave. So you have to do it daily during the first cycle. Okay, you have to start with that, and then for each cycle you have to do class 5 indicator. So in the CSSD main register, where you write about your cycle, there you have to mention, there you have to paste the class 5 indicators as well. Okay, in certain new generation autoclave, you have those printouts, so there you can paste this thing and keep it in a file. That will also do. Okay, and then the third one is biological indicator. So NABH mandates that you have to use the biological indicator at least once in a week. Okay, in certain high-end super specialty hospital, it is done in those cycle where those instruments being used for those OT procedures are used. So they also use a small machine I don't remember the name of the machine, but it helps you detect the biological indicator, whether it has passed or failed in 3 to 4 hours time. Okay. Then we have the biomedical waste management. So there are videos I had uploaded separately. How do you remember these 4 colors and what to dispose in it? So please check out that short video in my YouTube channel. You can also see that in my Instagram. So first, the segregation is very important. So for the housekeeping people, what they need to do is they have to place the dustbins in the right places. Okay, and they have to use the right dustbin. So dustbins which are foot operated, those are good, and dustbins should also always be covered. So there are certain dustbins which has a object, something like this, where you have to put it and then it dangles like this. So those kind of dustbins are not recommended, because in the cover it has chances of retaining those infectious bacteria. So always go for the foot operated dustbins. Okay, so placing the right dustbins in the right places, and then they have to do a periodic check. So the periodic check has to be done by the housekeeping supervisors and the ICN. Every day she or he goes on rounds, and the ICN checks for those dustbins, whether those are okay or not, whether it is 2/3 filled, more than 2/3 filled, they check it. Okay, and after checking, if it is full or 2/3 filled at least, then it is cleared. So the periodic clearance is essential. Then the transport and storage. So for example, this whole transport thing is very important, because the housekeeping people, when they have to transport it, first they have to wear proper PPE. They should wear hard heavy duty gloves, they should wear proper apron, they should wear those gumboots, they should wear mask and all. And while they are transporting the bags, they should use a trolley which is covered. And for yellow, they should have a yellow trolley. For red trolley separately, for blue, white, and or they can have a single big trolley where they can put all those different color coded bags and the boxes separately in it. Okay, so that's for BMW management. Then comes the housekeeping and infection control. So on the left side you can see housekeeping, they have to do periodic cleaning of rooms and toilets, corridor and other open spaces. Okay, so they need to have a checklist that they have cleaned this on this time, and who has done it, who has supervised it. So those records should be there in those respective places. Okay, then they should daily change dustbin bags. Okay, the yellow ones, the red ones, the other ones if it is filled and not, and for the general waste they should also change the dustbins. And then the bed sheet, pillow cover, those things needs to be changed on daily basis. In a government hospital nowadays, in South India, many photos you might have seen where the bed sheets, the date, weekdays are written as Sunday, Monday, Tuesday, Wednesday, Thursday, Friday, Saturday, and then Sunday again. So these bed sheet, when those are written, that means you would know that every day it is changed. Okay, so that's a very creative and very intelligent way of monitoring whether those bed sheets are changed. And then the patient uniform should also be changed on a daily basis. So when you do these things, then the patients, they also understand how clean these hospital, they are, the effort for cleanliness, they'll start to see and understand that. Okay, and in terms of infection control rounds, so the ICN should be checking daily their housekeeping activities, whether those dustbins are properly being maintained or not. They should counsel the patients on waste management. The ICN, especially for the medicine patients, the non-surgery patients. So for those patients, the ICN should see the peripheral line. The ICN should see whether the drips, IV drips, they are flowing at the desired rate or not. If it is not, then you need to check the IV line, whether there are any swelling or not. If there is a swelling, then you have to put ice packs. Those things needs to be checked by the ICN. In other departments, ICU or in surgery wards and all, nurse will, the ICN will surely check for SSI, CLABSI, COTI, VAP. Okay, so that is there naturally. And then the patient, they need to be counseled. The patient and the attendant needs to be counseled by the ICN that you have to, not just the ICN but also the nurse, they can do that. You have to dispose these kind of waste here, and one for the biomedical waste and another for the general waste, and not to mix it. So those counseling should be there. So let's move on to the next now. Now talking about lab operations. So it starts with from the sample collection. So sample collection side. So before going to the sample collection, the patient has to register. So in OPD, what happens is you have to give the prescription where the investigations are written, and you do a registration, pay the bill, pay the amount, and then go ahead for sample collection. And if it is done from the IP, the nurse, they collect samples and they send it to the lab. Okay, so the sample collection, so here there are several things. So you can see my lab video for this, for a detailed explanation. Okay, so the sample collection here, from the sample collection, the sample is transported in a ice pack box where biohazard symbol should be there. So in the ice pack box, it is transported to the lab. And if you are using if you have a pneumatic chute system in your hospital, then it is very easy. Once you collect the sample, then and there you send it to the lab via the pneumatic chute system. Then you receive the sample, you segregate the sample, and according to the labels and all, you give it to various departments. And then you load the samples. You process the sample like you centrifuge it. After centrifuging, you load the sample and carry out the test. So it is done by the equipment. So you can have semi automatic or fully automatic equipment. And once you have the results done, then you prepare the report. So if you have a proper LIS, then which has a integration with the interfacing with the equipment, then you get the reports directly in your system, and through the system you generate the report and send it to the authorized signatory for verification. So from the technician level also as well, they analyze and see if there are any critical parameters which are showing critical values. Then they generally rerun the sample, and after verifying it, then they put it that it is critical and it is verified. They change the values, and if it is not, then they change the value and say it's not critical. And once it is critical, then they talk to the consultant. Okay, so you need to have a critical alert register, and there you need to write all that. Okay, then report preparation is done, then it is gone for verification to the consultant, the authorized signatory of the lab. So the clinician, they see the report, and using their clinical judgment, they verify the report and they approve the report. And if there are any inconsistency in the report, then they ask to rerun certain tests again to the technician. And once the test report is satisfactorily complete, then it is signed and it is given. Okay, there are several processes, like there can be return of the report, recall. So that's a different process. I'll just cover about the quality control aspect of this. So there are basically three main types of quality control. One is internal quality control, where the lab runs controls in various levels. You can have 2 levels for biochemistry, 3 levels for immunoassay, or for HEMAT. NABL suggests that you do at least 2 levels at a time, and you have to cover, if your hospital is 24 hours running, then you have to cover the whole 24 hours. Every 8 hours you have to run controls and verify that your equipment is producing the right result. Okay, so to verify it, you use Levy-Jennings chart, you use Westgard rule to verify that, and that's a different topic. I'll cover that sometime later on. The second thing is ECAS PT. So ECAS, External Quality Assurance Scheme, where or proficiency testing, where several labs, they get sample from a single agency, and they put all these labs, they put their respective results, and each parameter from all the labs, they are put in a normal curve, and the Z value and all, it is shown. Okay, so accordingly you understand where do you lie. So it is always said accuracy and precision. So accuracy is seen through IQC, and precision is seen through IQC, and accuracy is seen through ECAS PT. And also ILC, where you are comparing your result with other labs who are NABL accredited, and they follow quality process all the time. Okay, so this you can do when you don't have ECAS program for your parameter, or you can do it whenever there is a outlier of your ECAS. Okay. Now the operations aspect of imaging department. So Again, emerging department starts with registration. So there the patient goes and gives money and registers itself as per the prescription, as per the investigation recommended by the consultant in the prescription. Then the radiation technician, they screen the patient whether the patient is okay or not, whether there can be several different kind of screening that can be done. Say for example, if the patient is pregnant, if the patient has any metal parts inside, or for say for example for contrast the creatinine level is checked. So screening. So after screening, the patient might require mild sedation. So for mild sedation, the monitoring recovery of the whole mild sedation should be seen. Okay. In many of the cases, 90-95%, it is not required. So the procedure happens inside the CT, X-ray, or whatever. And after the procedure is done, then the reporting starts, where the radiologist, they write the reports and then it is released. Okay. So the reporting part. Another safety aspect of this is the TLD batch. So TLD batch is sent to Elora every 3 months, and they tell you how much of radiation these staff they are getting. So accordingly you have to take necessary actions. If a staff is exposed more to radiation, then you have to keep the staff away from that department and give him a break. So, and you cannot use that staff in that department, and at the same time you cannot fire the staff. Okay, so you have to keep the staff away from that department. Then comes your lead apron scanning. So I generally say tell my hospitals to scan the lead apron in CT so that you get a larger image, and for any cracks, if there are any cracks, that can be discarded, and you have to get a new one. You cannot use that because through those cracks you'll get radiation exposure. And at the same time, when you do the scanning of these lead aprons, you have to get a report from the radiologist that these numbered lead aprons had been scanned and no cracks had been found or minor cracks had been found, and recommendation whether it can be used or it should be discontinued. Okay. And the radiation assessments. So there are certain third-party agencies. You have to call them, and they check the radiation levels in different places, and then they give you a report. Okay, and accordingly you can there would be certain recommendation in terms of infrastructure, or there can be certain adjustment which are required in your radiation equipment to achieve ALARA as low as reasonably achievable. So accordingly you have to make the changes. Okay, so this is for radiation. Then comes your OT operations. So OT operations starts with OT scheduling. So OT is scheduled one day before. So today by 5 p.m. 6 p.m. the whole OT staff, they get a OT schedule for the next day. So whether it is anesthetists, the consultants, the nursing staff, technicians, housekeeping, pharmacy, CSSD, store, they all get this notification, and accordingly they have to prepare for those OTs. Okay, and outside every OT they have to have a OT schedule board where they write all the planned surgeries. Okay, then your PAC. So pre-anesthesia checkup is essential. So the anesthetists, they do that, and through this they see whether the person is okay to go for surgery or not. That clearance has to be given by the anesthetist. And in certain emergency cases where you don't have so much time, only the required vitals are checked, and accordingly the surgeries are carried out. Okay, so PAC is very important. Then inside the pre-op, at the time of day of surgery, the time of surgery, the patient is prepared in the pre-op bed, and they undergo another pre-anesthesia, another pre-surgery checkup, and then if everything is okay, then the patient is taken inside the OT. So after the OT procedure, so one thing I would just add here is the OT utilization. So to understand the OT utilization time, the OT utilization starts from the time when the patient enters the OT and the time the patient exits the OT. So that is the OT utilization time. Okay, not the time when the patient comes to the OT complex, stays in the pre-op, not that, but in and out of the OT. So those times are written down in the main OT register, and through that the OT utilization time is calculated. Okay, so then post-op, the recovery. So the patient goes there, their vitals are checked, and as per the LRIT score, the patient is then discharged to wards. Okay, so then the patient is shifted to IP. And then there are certain other aspects of OT management. So CSSD item, how those CSSD items are coming, how those are stored, how those are being used, how those are being sent back to CSSD, that aspect. So the infrastructural requirements is very important over here, and if your infrastructure is not helping out those, then you have to make certain big process improvements to mitigate that thing. Okay, then the medicines. So you have to have a proper medicine storage and segregation, everything in the OT. And then implants, another thing. So medicines or implants, it is these things are part of the formulary. Okay, so if you are using implants, you have to put it in your formulary as well. Okay, so implants, what kind of implants is being used. So there are basically 3 stickers which are required minimum for implants. One goes with the patient in the discharge summary, one goes to the MRD, and one with the implant register. There they put the sticker and keep a record for what implant exactly was put inside that patient. Then comes your BMW movement. So the biomedical waste movement is very important. It should not cross with the same place where the sterile items are coming. So it is very important. And when you don't have your infrastructure planned accordingly, then you have to use certain other consumables to mitigate this problem. Then comes your consumables. So other consumables other than your medicines and all those, so proper storage, maintenance, reorder level, everything needs to be taken care. Then comes your infection control. So infection control, OT, very important. So how your ACs are functioning, how what kind of the swab cultures you're doing, the cleaning that you're doing, all those are very essential in terms of infection control in OT. Now, in terms of your manpower rostering and shift management, the most important one is the medical officers duty rosters. So you have to have cover the whole patients with your medical officers. So the consultants, medical officers, and the nurses. So consultants will basically talk to the medical officers. The medical officers will have all the information about the patients which are there in the IP. So you have to take care of the medical officers duty rosters so that you are not overburdening them with long shift where they can have a difficult decision making. So you have to be very practical with the duty rosters. So in general, 12 to 15 patients per medical officers is general ratio. It should not be more than that, otherwise it gets very difficult for the medical officers. And the work hours as per the law of the land, generally 48 hours is a limit per week. So if you are following that, then okay. So medical officers duty roster, very important. So then nurses duty roster. So nurses duty roster, another thing. The difference between nurses and the medical officers, there are more nurses required. So as I said, 12 to 15 patients, you need one medical officer. For nurses, depends upon the place, the ward. So for ICU, non-ventilated, 1 nurse for 2 patients. Ventilated, 1 nurse, 1 patient. For OT, 3 nurse for 1 patient. For cabins where you have single private cabins, 1:4 is good. 1:5 for ward. Okay, and you should have 30% of your nursing staff for rotation. Okay, so that is for nurses duty roster, and generally how it should be followed is the best nursing duty roster has morning, 2 days morning, 2 days evening, 2 days night. So morning 6 hour, evening 6 hour, and then night 12 hours, and then 2 days off, and the cycle goes up like that. Okay, then you have your operations duty roster. So in terms of operations, you have to have a 24-hour listing. So it's not just the daytime people who are there, operations people, but it also during the night there has to be a night duty officer, night hospital manager as well. Okay, assigned. So the duty roster of operations people are also essential. Then other departments like pharmacy, housekeeping, lab, radiology, your maintenance, all these things has to be covered around the clock. Okay. So thank you so much for watching this video till the end. Please share what you think about this, and please help me grow my channel by putting your thoughts into it so that I can improve. Please comment, like this video, share this video, and please subscribe and hit the bell icon for notification. Thank you and see you again.